Hi, this is Starlin Imperial and Catherine Putnam. We're going to be doing the Dubin Method EKG interpretation. All right, so the EKG that's up, we'll start with the rate. Starting in the lower part of the EKG in lead 2, there is a rate as you measure the R to R interval. It can be 300, 150, 100, 75, 60, and looks like the rate is 50 beats per minute, the ventricular rate. And the atrial rate is 300, 150, 50 as well. Moving on to the rhythm, there is a P wave to every QRS complex. It is not a junctional rhythm, being that the rate is between 40 and 60 because there are upright P waves to every QRS. So this is a sinus Brady rhythm. The R interval is less than 0.2 seconds. I know that because it's within one large box. And the QRS complex is less than 0.08 seconds. So there's no bundle branch block or any ventricular foci, because you would have a large QRS complex. Moving on to the axis, I'm going to be looking in V1. The R is positive, going upward, and in AVF, it is also going upward, so there's no axis deviation or normal axis deviation. For hypertrophy, I'm looking in V1 at the S wave. The S wave is very large. It's 1, 2, 3, 4, 5, 6, almost 7 boxes just in V1. And then in V5, the R wave is also very large. So I know just by looking at this that there is a left ventricular hypertrophy, which means that there is more than 35 millimeters when you add the V1 and V5 S and R wave together. Lastly, ischemia. I'm looking for any T wave inversion. There is T wave inversion in lead 1, lead 2, lead 3, this tells me that in these leads that there's possible ischemia, lead 1 being a more lateral ischemia and lead 2 and 3 being more inferior. This is the circumflex and RCA that may be affected. Then looking at ST elevation, you can see that there is elevation in V1, V2, V3, V4. And this tells me that there is injury to the anterior septal and anterior lateral, which is the LAD, and possible circumflex. There's also T-wave inversion in V6. I did not state that before. This can also mean that there is ischemia to the circumflex. I do not see any pathological Q waves, meaning that there is not a wide Q wave being more than 0.04 or there's none at all. So there's no necrosis. So in summary, this patient is sinus Brady with injury and ischemia to the lateral and anterior leads affecting the lateral, anterior, and inferior. So it could be affecting the RCA, the LAD, and the circumflex.
Okay, how do I start my...
I guess try to share your screen. Yeah.
Should I only have this screen open then?
It'll give you a choice.
Oh.
whichever. I think it's that one. No, that one.
Do you have mine? Okay. I'm looking at yours still, actually. Why am I looking at yours? I don't know.
Okay.
So where's mine? I just go to it on here instead.
No, yours is up now.
But like it's not on mine.
Oh, you can go to it.
I
Yeah,
just
after.
read it on here. Okay. Can I use your little card? Thank you. Okay. And I am Catherine, and I'm also going to interpret this EKG according to Dubin's method. We'll start with the rate. The ventricular rate is 100. And the atrial rate is around 100 as well. Next is rhythm. It's right on the border of being non-sinus or sinus tach. There is a P wave for every QRS and a QRS for every P. The PR interval is less than 0.2. The QRS is less than 0.12. So we have sinus or sinus tach. It's 100.
It would be sinus tach.
Okay. So sinus tach, normal sinus tach. Next we do axis, and I'm going to look at lead 1, which is mostly a negative QRS, and lead AVF, and that has mostly a positive. So we are going right
Axis
deviation. I think it's extreme right axis deviation, which would be between -90 and -180 degrees. Next we have hypertrophy, and I'm going to look for atrial hypertrophy in lead B1, and I'm looking for a diphasic P wave, which I do see throughout lead B1. Is not present in V2, V3, V4, V5, or V6, just in lead V1, which is what I would expect. For left ventricular hypertrophy, I look first in lead V1 for a large S wave, which it is not abnormally large, in V5 for a large R wave, and this is also not abnormally large. It's mostly isoelectric QRS in lead V5, so no evidence of left ventricular hypertrophy. For ischemia, I'm looking for inverted T waves, and those are present in lead 3, AVR, V1, V2, V3, V4, and that's it. And the inverted T waves indicate ischemia. And next we look for infarction. So I'm going to look for pathologic Q waves in ST segment elevation or depression. For pathologic Q waves, let's see, I do not see any, and that would be defined by width greater than 0.04 or height equal to or greater than 1/3 of the QRS complex. So ST segments, let's see, in V1 it looks depressed, as well as V2 and V3 and V4. Slightly in V5 and normal in V6. So in summary, we have a sinus tach rhythm with extreme right axis deviation, and right atrial hypertrophy, and ischemia present in the leads V1 through V4, which is the anterior aspect of the heart. And then our ST depression is also present in V1 through V5, and it was slight. So I would suspect a subendocardial infarct of non-Q wave variety. They might all be non-Q wave. And the anterior infarcts are caused by blockage of the left anterior descending artery.
Okay. Thank you very much.